All right. Good morning, everyone. Thank you for joining us for the second annual Black and Immuno Week, a week where we will celebrate, or we have been celebrating, amplifying and supporting Black voices in immunology. Before we begin, we would like to thank our major sponsors, the Immune Deficiency Foundation and Imperial College London. Don't forget to tweet about our session today using the hashtag patient advocacy with each word capitalized for accessibility purposes. We will have live captions and ASL interpreters during these sessions. And you can also submit questions through the comment function on the platform. Not the Q&A, but using the comment function that you should see to your right if you're on a mobile device or other platform. As a reminder, we really want to create a safe space around these topics, and so we're asking all our audience members to continue to be polite and respectful while in this space. If we do see anything offensive, we will delete your comments and you will be banned from the platform. After the conclusion of this week, recorded videos will be posted on our YouTube channel and transcripts will be made available on our website at blackinimmuno.org. So with that said, I am so excited to introduce this panel. My name is Shayla Shorter. I am a Special Assistant Professor of Biology at Hofstra University on Long Island, New York. And I am also the sponsorship and partnership lead for Black in Immuno. And I will be the moderator for this panel today. I want to welcome you to this panel session that's focused on patient advocacy. And we really hope to have a great conversation around what patient advocacy looks like and how researchers can be aware of how their work is impacting patients and how they can be involved in supporting patients and really considering their best interests as they do the wonderful work that they do. We have 4 great panelists with us today. And I will have a few questions for the panelists, and at the end, we'll leave some time to open up for questions from the audience. So I'd like to just briefly introduce each of our panelists. So first, we have Dr. Shilpa Venkatachalam. She is the Associate Director of Patient-Centered Research at the Global Healthy Living Foundation, Creaky Joints, and co-principal investigator of Arthritis Power Patient-Powered Research Network. She is also a rheumatoid arthritis patient who has been living with the disease for 4 years. She has completed her undergraduate degree in Mumbai, India, before moving to the UK. And she earned her PhD in critical theory at the University of Nottingham, UK. And we are so happy to have her on the panel today. Next, we have Lisa Agyen. She has been living with long COVID since infection in March 2020. And as you might know, long COVID is a new an emerging disease that is misunderstood or not well understood. And so it has been the patients with long COVID that have been driving the inquiry into this space. But Lisa has become really active in this space since joining the long COVID support group in autumn of 2020. Her involvement in co-authoring a an article in The Lancet, as well as joining the NHS Long COVID Task Force meetings, have been essential for providing patient input into understanding the experience of patients with long COVID. She's currently a program manager in the civil service, and she's worked on a number of different programs. She is of Ghanaian heritage and lives in South London with her husband and 3 sons who are football crazy. Next, we have Dr. Faye Bruce, who has done a lot to address health disparities in the Black, Caribbean, and African community. She is a clinician and an academic who leads programs in health at Manchester Metropolitan University. She is the chair of several organizations, including the Caribbean and African Health Network, which is a network formed in 2017. And its mission is to eradicate health disparities for within a generation for Black people. And she's doing amazing work in a number of different organizations. She is working currently on looking at the role of racism in nursing and how that interplays with reducing risks in maternity-related settings. Lastly, but not least, we have Syreeta Nolan, who serves as a co-founder of Disabled in Higher Education on Twitter. And she is a board member of Health Advocate X, and is also a founder of JADE, JADE, which stands for Justice, Advocacy, and Disability Education. And this is a holistic platform aimed at empowering disabled students, faculty, staff, and alumni through the higher ed community and beyond. She is on the cusp of graduating with her bachelor's in human health psychology from the University of California, San Diego. So congratulations, early congratulations to you. And so her lived experience as a Black, Indigenous, bisexual, disabled woman has really informed her advocacy goals. And she hopes to continue to obtain a PhD in health policy or prevention science in order to transform the mental health field beyond what we currently have. So we have, I say all of that, I give all of that introduction to say that we have an amazing, amazing panel ahead of us. And so I'm going to start off this discussion with just establishing the foundation of what patient advocacy really is. So I'm going to bounce this to Shilpa to start. What is a patient advocate and what does it look like for you?
Thank you so much. That's a great question. And I'll start off, I suppose, by saying, patient advocacy can mean so many different things, which is why we're probably going to hear from all the other panelists. But in the end, I think it always comes back to amplifying the voice of the patient and putting the patient at the center of healthcare, whether that is policy, advocacy, or research, or even regulatory decision-making. I think it also means providing, as a society, it means providing the right platforms and constantly leveraging those right platforms to patient communities so that they can find the platforms to voice their concerns, their values, their preferences while making decisions and while helping society make the right decisions within healthcare. Beyond that, it means, I think, removing the barriers that add to patient burden, identifying the right barriers, the gaps, etc., not just in research, not just in policy, but also in clinical practice. So it really is very broad sort of brushstroke here that I'm trying to give of what patient advocacy really looks like. I myself, have advocated as a patient for myself, and I learn constantly from our patient community. So it also means society and organizations, and I'll bring my organization here as an example. So we at the Global Healthy Living Foundation are constantly working together with our communities of patients, but also alongside other stakeholders like clinicians and researchers and regulatory representatives, payers, insurers, providers, etc., to come together to enable those conversations, really to bring the lived experience of patients to the forefront. Because that is, I think, at the crux of patient advocacy, is to realize that there is a value that we don't see maybe in lab reports and clinical data, etc., that can
Right.
only come from the lived experience of the patient who lives with a specific condition day in and day out, and really paying attention to those kinds of things. That is data. And so combining that data, allowing platforms to enable the voicing of the lived experience of the patient, putting that right at the center. So I'll stop there and allow the other panelists to come in as well.
Absolutely. Thank you so much for that. Definitely highlighting the lived experience of the patients and integrating that into our understanding of a disease is critically important. I'm going to bounce the same question over to Syreeta because I saw her doing the snap clap there. So I need to know what popped up in your mind when you considered this question about what does it mean to be a patient advocate?
Oh, I love this question because it's so multifaceted. When we think of a patient advocate, this could be someone that's assisting you. Like in my work with Health Advocate X, I've learned about this professional field of health advocates that can be hired to help support, like with health coordination issues. But then there's the barriers within that as well, as it's usually private pay. There's patient advocates that could be at a hospital to help support patients when things get difficult. But then there's myself. As a patient, I do have to be my own best advocate
Mhm.
to advocate when something feels wrong. But it doesn't always turn out well. Like when we advocate, like especially in my own health, I've dealt with medical trauma, sexual abuse in places where I should have been safe. And patient advocacy should not just be weighed on the patient or whoever the patient asks for help, but it should also be woven into the training of our medical field. I wear this Crip Camp shirt because it's this amazing movie that celebrates the culture of the disability community. And I think if that was woven into trainings, patient advocacy would be a part of these trainings. How we experience neurology, for example, as disabled people would be there. How we experience EMGs, how we experience our treatment and our lives. Like patient advocacy shouldn't be an afterthought, it should be a forethought. It should be something that transforms our medical systems rather than when everything is hard, a patient has to reach out. When everything is hard, a patient has to advocate and say, no, wait, I think I still have this issue that I'm dealing with. And patient advocacy, it's like that word patient, calling us to be patient when the field isn't patient with us, when they listen to respond and not to understand what we're actually saying. Definitely being a black and brown patient, it's much worse in our society here in the US. And APHA has named racism as a public health crisis, but not yet ableism, and it should be.
Oh, thank you so much for that, Sarita. You brought up a number of amazing points, namely one about patient advocacy being about helping other patients, but as a patient yourself, like learning how to be an advocate for yourself. That dual responsibility that you have. And then I just love the idea of the play on words that you just used, with patient meaning a person who is dealing with a disease, but also patient as in to be kind, to be long suffering, that sort of word. So I really love that play on words that you use. I'm going to pass it over to Lisa because we've been the definition of patient advocate around you know, speaking up for oneself and integrating knowledge of what's happening on the ground level and integrating that into the understanding of the disease. I think this is particularly salient when it comes to COVID. COVID has only been around since December 2019, and so the field and our understanding of COVID is rapidly evolving. Lisa, as a long COVID patient, how do you? I mean, I imagine that you're playing a central role in helping us understand this global health emergency.
Well, I'm trying to be it's quite funny because, you know, when you said what does patient advocacy mean to you, if you'd have asked me that 2 years ago, I wouldn't have had the slightest of what you meant. I wouldn't have even known what lived experience had meant, because I was a relatively healthy person. I had no health issues, so I never had to kind of interact with the medical services, especially, you know, if I did, it was just like maternity standard things that, you know, every women might go through. So I think with the emergence, what it means to me with the emergence of long COVID and what my experience was, it means a bit like just shouting out and speaking the truth, and trying to draw as much attention as possible to what you and your fellow sufferers are going through. So that's for me. I'm not a medical person. I have no medical background or training. So it was at the initially just trying to, patient advocacy was us talking to each other about what was happening to us and trying to find answers. And then once I established that there was a community. Well, I hope I haven't frozen, because everybody.
No, you're fine. We can hear you and see you. Oh,
Can you guys still hear me?
we can hear you.
You all disappeared, so I was a bit worried there. As I was saying, once I'd established this community, it was then about, okay, we all knew how sick we were, and we all knew we weren't getting help. But then we were all in our community talking about it, and that's not going to do anything. And, you know, my personality is much a driven kind of doer kind of person. So, I like complaining. So it was really just kind of finding a different forum where I could say, hey, you know, this is going on, and complaining to as many people as possible, and, you know, coming off the closed Facebook group and then going public and actually shouting out, guys, you know, open your eyes to this. That's what patient advocacy is for me at the moment. And obviously also volunteering as a Black woman, I did find that most of the people in the community were more white or Caucasian, middle-aged, kind of middle-class women. And there's nothing wrong with that. They were experiencing the same things that I was experiencing, but it was just that they were shouting out. They were the other people that were making it known. So when we did get attention from medical professionals, they just assumed it was something that only happened to white, middle-class, middle-aged women. And so they weren't really taking in that there was lots of other people, and specifically in the UK anyway, it was Black and minority ethnic people that were actually suffering the most with actually catching and suffering from COVID. So we weren't in the conversation. So that was another reason that it really drove me to just say, no, hang on, I need to put my hand up and let people know that there's people like me, and encourage people like me to come forward as well, if you know what I mean, and just spread the message. So that's what it means to me, patient advocacy.
Right. I think, you know, it is, you brought up several points that are so critical. And, you know, I want to bring in Faye on this part, because when it comes to patient advocacy, on one end, you know, it's about advocating for the needs of the entire community as a whole, right? In terms of access to services, and so disease specific kinds of things. But then there's this racial ethnic component to this, right? So when you integrate the inequities in the system, when you integrate the impact of racism and differential treatment of people in the system, I don't know, Faye, would you say that gives patient advocacy a different meaning when it comes to people who are considered minorities in their society?
Yeah. Thank you. Yeah, absolutely. I think we have a real need for patient advocacy as Black and brown people in the UK. And I think so much is, we've learned so much, haven't we, over COVID? Obviously, many of us have been doing a lot of this work for many years now to try to empower people, Black and brown people, to be able to have the information that they need to be able to self-manage and self-care and to get better outcomes for them. And I think what we've seen really, certainly over the last 20 months, is the fact that, you know, our voices haven't really been heard, you know, whether it's information that's being produced around COVID, for example. The system hasn't been hearing us. We've been saying for many years now, you know, things need to be done differently, culturally, religiously, racially, you know, bringing about that awareness and embedding that into what we actually need, the information we need to be able to have better health outcomes. And because we've not had that voice around the table, we've needed to have people that can advocate for us, to be able to go into those doctors' rooms, into those hospitals, to say, hang on a minute, what about this? So we've not really had that kind of racial lens as a, you know, public health or GP services. They haven't really seen us, you know, and therefore we have been left behind. So where we have all those worse health outcomes, and people say, oh, I didn't realize that was happening to Black people. Well, we've been saying these things for some time. So that patient advocacy, and I often say, you know, I mean, I have the experiences of going with my mom, you know, to a GP practice and to her hospital appointments, and you see mum's face, and she's really kind of, you can see how nervous she is. She doesn't want to speak up. She's worried about saying the wrong thing. And we've been having health hours now since May last year, which has been all about empowering our community. So every Saturday between 11 and 12:15, we have a Black clinician or just a Black health professional come to talk to hundreds of people in our community about conditions that are prevalent to them. And it's all about, how do we empower? How do we give people confidence when they approach or engage with our health practitioners, clinicians? How do we ensure that they've got the tools and the information that they need to be able to advocate for self? But if not, bring somebody along that knows exactly how to navigate the system or to enable people to get the best out of, you know, the health system itself. So it's really, for me, patient advocacy is really key. And we have lots of nurses that work in the voluntary sector in our organisation, simply because we need to have those people that know what they're talking about to step in when our people, Black people, brown people, aren't getting the service that they deserve. So there's a lot of work going on. The system has a long way to go. And you have to bring in organisations such as the VCSE sector that have a lived experience. We all have that lived experience. We bring us in. We know what it looks like to be excluded or not to be accounted for. So we utilize people from our own community, you know, to be able to support, you know, Black and brown people within health. And we've actually applied this to lots of other areas as well. It's not just about patients.
Yeah, no, thank you so much, Faye. Excellent points. And I a couple of the things you mentioned, I think that having the programming that you described, where you are giving regular, I guess, instruction, advice to people to help them advocate for themselves and to just have better health outcomes is so critical. I'm going to pose this next question to the entire group. So I know we're talking about patient advocacy in the sense of empowering the patient to advocate for themselves, to know what questions to ask, what to do, that sort of thing. But if you can think about patient advocacy as maybe a two-sided coin, where on one coin you're training patients to know what to do, how to advocate for themselves, but is there a side of patient advocacy where we're informing the clinicians, the researchers, the people on top, right? So if you could think, if you agree with the statement that patient advocacy kind of has this dual coin kind of thing going on, can you speak a little bit about what it would look like for patient advocates to make a difference from a top-down perspective? And, I would love to hear from all of you, because you all are in different spaces as it pertains to where you're doing your advocacy work. And so I was wondering if you can speak a little bit on that, and
I'll
anyone
jump
can
in.
jump in.
Yeah, I'll definitely jump in because it definitely is a two-sided coin where, as a patient advocate, I am working my hardest to make sure my doctor understands my needs, that a patient advocate will work to help me in that process as well. But outward facing, I feel like it looks like disability advocacy. And the way that disability advocates speak out on social media, come together as a community, and I feel like as disability advocates, when we come together, that we're stronger together to really make change happen. Like when CVS was trying to do something for disability discrimination, we came together to make sure that our voices were collectively heard. And I think another thing about disability advocacy is just the word disability. When we think of this word as a Black community, we may not initially think of strength, empowerment, and things like that. We may align disability with a construct of weakness. The Black feminist disability framework is one of my favorite articles, like, of all time, because it really aligns with how, in being Black, disability is not something we allow ourselves. And in disability studies, we don't talk about intersectionality enough. Most disability advocates are white. That's why long COVID, you see a lot of white advocates. Like within disability Twitter, disability to white is a hashtag that really amplifies how much we do have, like, we're a minority within a minority of disability advocates. Within every marginalized community, there are disabled people there. And I really think that also advocating just as strongly for disability identity, because I identify as a proud disabled Black woman, and my gender pronouns are just as important as my disability pronouns of neurodivergent, invisibly disabled, and a disabled woman. It's really how we think about disability and how we listen and how we come together. And I think that's how we really begin that top down, to take it from an individual patient to a disability community approach, to really make sure we have the support we need to. Because disability Twitter is more than just advocating together, it's my family. I talk about my good and my bad moments, and I can have my mice versus pain versus ADHD and my thesis thread, just to hold accountabilities and to hold space for each other. And Tanu does such a great job of holding space for disabled Black talk as well, because it is different to be disabled while Black.
Syreeta, I'm gonna give you a snap right there, because you said a lot, honey. I'm gonna still pose the question about, like, what does the top down approach look like? But I think you brought up an important point that I'm gonna ask the ladies to speak on as well, which is, about the cognitive dissonance that comes from being a Black or brown woman and being expected to wear the superwoman cape, but also reckoning with a disability. Like, how does one reckon with that? So that's, Syreeta, that's a huge question that you brought up. So I just want to put that in your minds. Just we'll probably get to that after this, but that is a fantastic point to consider. What does being disabled mean to a Black woman, a brown woman, Black man who is trying their best to stand in their strength in order to survive in communities that might be hostile to their existence. So Shilpa, I see you have your hand up. Do you want to talk about the top-down approach for patient advocacy?
Yeah, so I just wanted to add to what Syreeta was saying, and to what actually everyone's brought up on this panel is I think we have to really be careful here as we talk about advocacy to not always put the onus on the patient. We're a society. We have to start asking ourselves these questions: is that why is it why is it that today is just outrageous that we have to even advocate for ourselves and we have to scream out loud? Why is it that the system today in this century is failing? It's not that we're not aware of the fact that people of color, Black people, brown people, are getting diagnosed at slower rates. It's not the fact that people of color, Black people, brown people, have worse outcomes because they're getting diagnosed later, because we're missing diagnosis, because they're not taught in, for example, in medical schools, for example, lesions. And we do work in psoriasis and psoriatic arthritis. That's lesions on the skin look very different on white skin versus darker skin. And so we're missing these things. So we really have to start asking, and COVID sort of has shown us in a very stark way, in a very uncomfortable way, that these intersections, right, that the first thing you see is the color of your skin. It's just what you see as a society. And so why is it that we have failed, despite having so many conversations, despite the fact that we are aware? Why is it that we are failing and having patients now advocate for themselves? I think that really is the question to ask. And I see Lisa raising her hand, so I'll stop there again.
I didn't want to stop you. That was an excellent point that you made, just without even saying why do we need it. What I was thinking in response to the question of making a difference from the top down is get involved. And I didn't know. I mean, most people don't. That with when they're doing research studies on specific health subjects, they've probably got a budget for patient advocates to join or patients to be involved in the research. Who would have known that? They don't. Did they come out looking for you? With long COVID, they kind of have had to. So I gladly got involved with that. But I think maybe patients society needs to be more recognize that they can get involved, push the door open, and then the medical side should be calling you. They should be actively trying to get the information and the lived experience from the patients. And then the other point I was going to say, it was just really interesting when you said about being a Black woman, and from the cultural perspective, this is something that I really have had to think a lot about in this journey of lived experience and speaking out, is that in my culture for sure, we don't talk about our health problems. It's just auntie is sick, you leave it there. You don't find out what happened to auntie, or it's like, why are you airing your business to everybody? They don't want people to talk. And if someone gets cancer, for example, it's oh, she's got sick or she's got cancer. They won't even tell you what type of cancer. And it's just a bit cultural that we don't air our health linen. It's not dirty linen, but we don't talk about it. It's very much the kind of thing that you hide it in my culture, certainly. So I think that's something that I've had to kind of address and switch in my mind, is that it's okay to speak about how you feel or the experience that you've had. My mum might not be that pleased about it, but it's worth doing, and because it can show other people in your culture that you might be going through the same thing that they are. So that was the other point that I wanted to make.
Oh, wow. Okay, so now I'm seeing this less as a two-side coin, but maybe there's a third side where you advocate within your own culture, right? There's like almost a transforming of how we think about sharing information and passing that on, because you're right. I mean, you can, be asked, oh, have you ever had a certain, disease in your family? And you might say no, because you really don't know, right? Because people haven't been talking about it. So, oh my goodness. So what's something that has three sides? Is that a prison, a pyramid, or something like that? We gotta, as we create this multi-dimensional, as we're having this conversation, I want us to envision in a visual way, right? Like what we are dealing with, and the many fronts that we as patients have to tackle, honestly. And to Shilpa's point, it really shouldn't be all on us at all, right? But at the present time, it is, right? And so the question is, how do we, I guess, how would you advise patients to figure out what, let's see, what they want to tackle first, right? So, for instance, let's say someone is recently diagnosed with an illness, and they are either having trouble finding information, they are maybe having trouble navigating the health system. How would you advise them to to move forward, to get information, to figure out what they should be doing? Anyone can answer.
I'll jump in. I feel like I have a jump in habit. But I think that when we're advising patients to move forward, it needs to be something that's natural for them. Because when we are newly diagnosed with a disability, sometimes we just need to get our sea legs and understand what that means for us, how this transforms my life, what barriers am I experiencing in my own care, and working on that. And I think it's almost like a bottom up approach where you start at your individual place. You start at where it feels natural, where if you feel like being Black and living with your condition is the next space that feels most comfortable, maybe you move to advocacy, to your community. If you feel like there's barriers in how the medical community understands your condition, like, for example, like fibromyalgia is newly being considered as immunological, like trying to go to see, working more with researchers, like find the natural paths, but don't force it. Like when I wrote in my article the compounded burden of being Black and disabled student during the age of COVID-19, being newly diagnosed is something we don't talk about it as a grieving process, because each disabled person has not lived their whole life as a disabled person. I was diagnosed with fibromyalgia like maybe 6 years ago now. And I find myself, like, when that diagnosis happened, my non-disabled self was over there being buried. And if I lost a loved one, they'd offer bereavement support like Johnny on the spot right there. But mental health support for the grieving of the life you had before that diagnosis is not a part of our system. Like, so patients moving forward should also realize that rehabilitation psychology, psychologists that specialize in patients with chronic pain, that's important to really reimagine who you are and giving yourself grace to live with your disability, and realizing that disability isn't a bad word, and decoupling some of that internalized ableism before you jump out as an advocate and experience ableism in an external sense. So just being gentle with yourself as you move forward is the most important thing, I would say, because especially we have higher education that is very toxic once you're disabled as well. That's why I serve as a CEO of Disabled in Higher Ed, because being disabled is one of the most life-changing things, and we don't talk about mental health and disability enough. and it's something
Yeah.
that should be changed.
Absolutely. I mean, I think both that it's great advice that newly diagnosed patients should seek out mental health supports, but maybe this is also a call to the medical and biomedical enterprise to make this a part of standard of care, right? When a person is newly diagnosed, maybe that there should be a counselor, there should be someone who is dedicated to helping that patient deal with their new lived experience. Faye, I was wondering if I could bring you into this as well.
Yeah, absolutely. So many good points have been raised already. I think we're living in a society that is really quite frightening, to be honest. If you're a Black person living in the UK, experiencing a health system as what we experience, it's really hard to actually face up to some of the health issues that we may be diagnosed with, because for many, they don't know what's going to happen to them. They don't know how they're going to be treated, by the system. It's like we talk about mental health issues, for Black people. And we know if you're a Black person in the UK, and you've got a mental health, condition, or you're feeling not very well, not feeling great, and you want to go and see a health practitioner, there's a lot of fear in terms of going forward with that, because the data tells us actually that you're not going to be treated as well. So there are lots and lots of issues about why people don't come forward, why people don't accept diagnosis. But I also think the religious element of this as well is something, and I think Lisa mentioned about, within our own cultural space, there are certain things we say, there are certain things we admit are health issues, and our religious beliefs will deter us from actually engaging with health services as well. So there's a number of different things that we're actually grappling with at the same time. We're saying we actually want to have a better health experience, but there are lots of challenges in the system. And one of the ways that we've tried to address this as an organisation in Greater Manchester is that we've been commissioned to provide empower our GPs, our primary care staff, to be able to understand some of those challenges that we face as a community. So when we talk about, GP or primary care being the gatekeeper to health services, then we need to ensure that the GPs, the health visitors, whoever, understand the position in which we often come from, so they can, like Shilpa was saying, why do we always need to have our patients, advocating for ourselves? Why is the service just not there to cater for all of us? But what we need to do again is to look at how do we empower our clinicians, so we don't have that situation where we're having to bring somebody along with us to explain what's actually going on. We're trying to get clinicians to a point where they understand us as Black people, some of the racial issues, some of the cultural issues, some of the religious issues. So when we do engage, we have a much better experience. So as I said, there's lots of things we're grappling with at the moment, but it's just unfortunate that we do need to have that patient advocacy service, because we're nowhere near where we want to be at the moment.
Sure. I mean, you all have been bringing up so many great points. I mean, I feel like I have an explosion of follow-up questions for everything that you've said, but we are running close to the end of time. I will bring in Shilpa. I don't know if you wanted to comment on kind of what Faye was talking about regarding integrating culturally competent training into clinical education. How important is that, and how widespread is it currently? I know at least in the U.S., a lot of at least two historically Black universities have medical schools, and one of their central tenets, both I believe at Howard University School of Medicine and Morehouse School of Medicine, I think one of their tenets is to make sure that understanding the cultural context in which their patients are living is an integral part of treating that patient. You cannot treat that patient without understanding what they're dealing with much more holistically. So great point bringing that up, Faye. Shilpa, did you want to comment on that or bring something else up?
No, it is a great point, because we know that the practice of medicine is cultural. It has cultural, it has so many different cultural dimensions to it. Not only is the practice of medicine cultural, but illness is cultural too. The way you talk about it, the way you deal with it. Lisa had mentioned that it's a very private thing. Same with Asian communities and Indian communities. You don't talk about your illness. You don't complain about pain. That's just the given. So, we've been taught not to complain and to sort of keep it as a very private thing. I think the other thing is, doctors, clinicians here, uh, trust is a very important thing, and also very cultural, how you express trust. And we've had these conversations within my organization very many times, is, even a simple touch from the doctor on your shoulder is a very important thing in certain cultures. It creates trust. You invite your doctors in India to your house for lunch and for family celebrations and whatnot. So there is that implicit trust that's built outside of the clinic, that is really important for things like medication adherence, for things like letting the doctor know if your disease is out of control, for things like talking about symptoms if there are new symptoms emerging. So, there is the outside of the clinic and the inside of the clinic that are very integrated in certain cultures, that is missed often in other cultures. And so, of course, it's one of, I think, what Faye's point is really important, is that we have to understand that it's not just translating into a language that's going to do a trick. We have to think beyond that. What kinds of cultural components are attached to talking about illness and the practice of medicine as well?
Yeah, thank you so much for that. I think Lisa, feel free. I'm sorry, I didn't want
It was just that when Shilpa said something, and I think it does add to, like, is there enough promotion of patient advocacy opportunities for opportunities to communities and patients? No, broadly, because you might only find out about it when you're really sick and you want to complain, and but mostly importantly, as you said, Shilpa, they might translate something that's in a English leaflet in a GP surgery, but that translation is just words, and it doesn't really reach out and get the person to engage or to understand. Patient advocacy is more than just a leaflet, and I think it's really important for people to kind of speak to the medical professionals, to speak to people, or go to community groups to try and find the best way to communicate with people that may have a certain illness or a certain health condition within that community. It's not enough just to translate everything. Most of this patient advocacy stuff, which I've found, is all online, and there's so many people in our community that don't know how to use computers or don't know how to get onto a platform like this. So we need to kind of make sure that there's other ways so that we can make it accessible for all communities, and I think that's the medical people's professionals, their responsibility to be innovative and think of new ways.
That's absolutely a great point. I want to sort of, as we wrap up this session, the theme of our Black in Immuno Week is bench to bedside, and so you guys have brought up some great points about how important it is to integrate more of the patient voice and concern into at least the patient-facing roles, so your GPs and other clinicians. But as Black immunologists who may not have that role of being right in front of the patient, Do you have any suggestions or advice for researchers who are doing the kind of behind the scenes work on these illnesses that have a variety of kind of impacts? Do you have any ideas of about how to bring patient advocacy to the research sectors?
So I'm happy to quickly jump in here. So I actually work in the research arm of the organization. So I do patient-centered research. And so this question is really the focus of all my work. And one of the things that we do is we, there's a new paradigm now of research that's gaining momentum called patient-centered research, where we now understand that there's a certain kind of information that you see in blood work, like I said in the beginning, that in blood work and x-rays and scans, and there's a certain kind of information that you cannot access just through blood work, scans, etc. Things like fatigue and pain that go with a lot of immunological conditions that don't show up in your inflammatory markers, for example, but that you can only glean from the lived experience. And so I think it's the combining, bringing the responsibility today of the researcher, if they're doing patient-centered research, is to constantly find ways to bring together these two sets of information to understand these diseases better, to have checks and balances. We have a board of patients who serve as advisors on every research project, because we want to hear from patients whether a research question is even viable, is even relevant to the patient, is important to the patient. How do we study this research question? And then, at the end of the research, we've gathered all this information. Now, how do we share it with the community, give it back to the community? Because they've provided information about their lived experience generously. So we have to give them back something as well. We have to give our communities something back. So I think the main thing here is to always understand that this divide that emerged between patients and researchers has to break down, because in the end, we're citizen scientists. Researchers are going to be patients at some point of their lives, and so to break down these barriers, to come together as a community and to combine your expertise, whether that's through lived experience or through expertise in medical practice.
Excellent points. Excellent points. Syreeta?
Yes, I think I want to bring the flip side into it, that not only researchers may become patients one day, but disabled patients may have passions to research their own conditions and to bring that lived experience to the bench. Sorry, tongue tingles. But we don't just go from the bench to the bedside. You can go the bedside to the bench, and actually bringing greater accessibility into STEM and realizing the strengths that a disability advocate brings into research environments, like already knowing how to disseminate important information, knowing how to passionately pursue an area of research. And there's so much of higher education that is inaccessible to disabled people, this structural ableism that runs this system of ours in higher education. And it's really about decoupling that and making your research as accessible as possible, posting your postings with alt text, and being willing to see disabled scientists as equally valuable as scientists. And Disabled STEM on Twitter does such a phenomenal job of amplifying why we need more researchers that are disabled. And we also have mentoring opportunities through Disabled in Higher Ed and our partnership with Disabled STEM. So we are still recruiting. So because we need us. We need us to be at that bench to transform things as well, and not just be informing those who are at the bench.
Absolutely, absolutely. Syreeta, I'm telling you, I'm about to steal that hashtag bedside to bench. I'm gonna steal that one, because it is, you highlighted such a critical component that summarized basically what everyone has been saying, is that the information that the patient provides is critical to the entire understanding of these diseases, of how everything works, right? And so to to create these silos of information where it's only accessible to the researcher or the clinician, and to, you know, keeping medical or scientific articles behind paywalls is another issue that I could go on and on about. But the point that, you know, patients are largely seen as these these subjects that have no, you know, are not having interaction, that bidirectional interaction is just a wrong way to do it. And so I'm happy that all of you in your own way are working to break down those walls between the patient and the ecosystem in which they are operating in, and hopefully patients will be seen more as an equal partner in this, and as an essential key to really making progress in finding cures for disease and making real progress. We are about at the last minute of this, and so I am going to just thank all of our panelists for just sharing such great insight and just great advice. I mean, I think this panel has produced a challenge both to patient advocates in terms of, you know, encouraging them to continue the work that they're doing, but also a challenge to our research and clinical arenas that they need to be more involved in, and not have the onus just be on the patients to transform the system. So thank you very much, all of you. And thank you to all of you who are listening. I'm sure we'll see some tweets on Twitter about this. Again, if you are tweeting about this particular panel, we ask that you use the hashtag patient advocacy. Also, you could tag us hashtag BIIW, I believe, 2021. And in an effort to help us just pass the word of how we are connecting bench to bedside and bedside to bench. So thank you very much, everyone. We appreciate you hanging in with us.